Tony, thank you very much for this opportunity to share some of our ideas and thoughts with you. And I'm really sort of showing this picture from right from Derby, showing what the Victorians thought about science. And it reminded me how we are approaching the whole COVID-19 epidemic. Most of us are scared, as some of the participants in the painting is. Others are fascinated. And some of us are trying to shed some light on it, as the little boy on the right hand, trying to show what is the way forward. And I think that's really where we are right now with obesity, nutritional status, and COVID-19. Here are my conflicts of interest, and we work with lots of different companies, nutrition companies, surgical companies, medical companies, because we don't think that obesity is a single disease that will have a silver bullet. But what we are seeing is that obesity is one of the risk factors for patients to develop severe COVID-19. And we can see the other well-known risk factors being age, cardiovascular disease, liver disease. And what we are finding now is that obesity is becoming more important as we discover which patients are at risk of severe complications of COVID-19. Just to illustrate how our thinking has moved on, is initially we were thinking that vitamin D deficiency was also an independent risk factor. But that appears, as more evidence is coming to light, not to be as strong a factor, if at all. But it just shows us how important it is to put hypotheses out there, test them, and also for us to keep an open mind as we progress and learn more about the disease. One of the papers that's really changed my mind about COVID-19 appeared in the New England Journal, showing that, in fact, when we look at the histology of lungs of patients who died with COVID-19, that the pathology appeared to be on the perfusion side, not only the ventilation side. So it's not really the lung parenchyma that is diseased. It really has to do with the microvasculature around the lung. And we see this increase in microemboli. And suddenly it makes sense to us when we speak to our intensive care colleagues, and they say it's relatively easy to ventilate patients with COVID-19, but what they are finding is that there's a ventilation perfusion defect. So certainly if we think of COVID-19 as a disease that attacks the microvasculature, then suddenly it starts making sense to us why obesity may also be an independent risk factor, because obesity in its own right, together with the complications of obesity, are well known to attack the microvasculature of organs across the body. So the evidence started emerging from the US when they looked at the patients who had hospitalization because of COVID-19, and they saw that more than 48% of patients had another disease, and the other disease being obesity. So obesity was a very common disease that was diagnosed at the same time, or rather prevalent at the same time, with patients who were hospitalized for COVID-19. The French showed that there's a dose response curve. Looking at those patients who had severe COVID-19 and needed mechanical ventilation, we saw that if we look across the BMI categories, we see a clear dose response, with 85% of patients with BMIs above 35 that needed hospitalization and intensive care treatment. They actually also had to require mechanical ventilation. So we see that it is a common disease in people with COVID-19, but also that there's a clear dose response when we come over to the body mass index and how it increases across the range. So obesity appears to be associated with a higher probability of mortality. This is UK data showing us, of course, that we see that with age, the increase in age is a very important predictor and risk factor for death with COVID-19. But if we go down highlighted in red here, we see that obesity also appears to be an independent risk factor, together with chronic cardiac disease. And again, I will remind you of that observation in the New England Journal, that it's really the microvasculature that is the bed for pathology in patients with COVID-19 or severe COVID-19. And therefore, it suddenly, again, makes more sense to us to see just the strength of this association. Now, looking at obesity as a specific risk factor for COVID-19, also in a Mexican cohort, we see that this combination of obesity with COVID-19 becomes much stronger than obesity in its own right. So evidence that we have now shown from the UK, from France, from the US, from Mexico, so it does not really matter what jurisdiction you find yourself in. There seems to be consistency in the data when it comes to COVID-19 and obesity. So the increasing risk of COVID-19 related to death with increasing BMI was also shown within the UK population. So we can see that those patients with BMIs above 40 really had almost a threefold increase in the risk of death. Now, that's a very significant change, and that allows us to rethink our approach to obesity, not only as a comorbidity that leads to other diseases, but obesity as a disease in its own right with complications. And here we see that COVID-19, together with obesity, has significant complications, including mortality. So let's consider the potential mechanisms why obesity and COVID-19 can lead to more severe outcomes. So we understand the compromised lung function. Many patients living with obesity have a restrictive lung disease because of the increased adipose tissue on the chest wall, but also the combination with sleep apnea that again drives inflammation. Inflammation in its own right is recognized in patients with obesity. And just when we look at the CRPs of our patients, we can very often see CRPs of 5 or 6 in patients with obesity. And when we treat them, we can see how that significantly reduces. So if we have a already compromised state where people have chronic inflammation, we can see how additional inflammation by the virus can really tip the balance. And of course, we know that obesity has additional complications, complications that in their own right are recognized as risk factors for COVID-19 severity. These are, of course, type 2 diabetes, hypertension, and established cardiovascular disease. So really, it's almost like playing cards, and you can end up having a full house if you have obesity and the complications of diabetes, hypertension, and cardiovascular disease, and you then contract COVID-19, you are really in a very difficult situation. So what has been the impact of COVID-19 on everyday life and treatment of people with obesity? First of all, we have to recognize that our entire world has changed, and the way we will practice in the post-COVID-19 world will be significantly different to how we practiced in 2019, for example. Because what we saw during the height of the epidemic is that most of the weight loss programs were either curtailed or stopped altogether. So people who needed help with the disease of obesity or with complications of obesity were not able to access that. Moreover, we were asking people to self-isolate at home, and especially when the data became apparent that obesity is the independent risk factor, that these patients should also cocoon or shield themselves. And that, of course, increased sedentary behavior, enforced sedentary behavior, that further disrupted the disease of obesity. Now, of course, if you are self-isolating at home, very often your choices of food can be restricted. And we heard conflicting reports from patients. Some patients reported that, in fact, it gave them the ability to control their environment because they were far more able to influence what they were doing on a day-to-day basis. But many people reported that the quality of their diet deteriorated. They were not able to go out and shop for fresh food and vegetables, for example, and had to rely on items with a longer shelf life, canned foods that typically also have a higher salt content, higher sugar content very often. So the quality of the diet was significantly influenced. But many of our patients reported this significant psychological impact of the disease. And of course, if you were engaged in psychological support, suddenly that was changed dramatically. So the impact has really been far-reaching, not only for healthcare professionals trying to help people with obesity, but also for people living with obesity themselves. If we summarize, we would say that COVID-19 and obesity, that patients living with obesity do not have an increased risk of contracting SARS, but they do, in fact, seem to have a higher risk. And obesity is one of the most prevalent diseases amongst patients that are hospitalized for COVID-19. And that there is a further increase in risk of complications in those patients who have obesity and COVID-19. If I summarize, I would say that obesity causes higher risk of complications and adverse outcomes of COVID-19. We also see a higher risk of hospitalization and critical care, and the intensiveness of patients being managed on an intensive care unit. And the current pandemic has highlighted that obesity not only increases the risk of long-term complications, but also increases the risk of acute complications and severe outcomes. And this health crisis that has emerged from the COVID-19 pandemic reinforces the need for making obesity a healthcare priority. Providing access to obesity care will reduce the burden of people living with obesity, health systems, and societies. And this allows us to pause now and to think, how are we going to address the epidemic of obesity in a post-COVID-19 world? We have the ability now to reconsider everything we've done and see where we can make corrections in our course of action to actually help patients better to prevent the complications of obesity as life moves on. So please allow me to thank the team at home doing all the hard work, as well as our international collaborators. And we, of course, use our social media platforms to drive the evidence that obesity is a disease that needs treatment. And obesity is not the fault of the individual, but rather the responsibility of both the individual that suffers with obesity and us as healthcare practitioners. So thank you very much.
Thank you very much, Carel. So question, I actually don't see any questions on my panel in front of me at the moment. So in the meantime, could I just ask you, in terms of addressing this, obviously there's an option for looking at short-term changes and long-term changes. Could you suggest what you think public health authorities and national health authorities may now consider in terms of how to address the issues that you've just described? What suggestions would you have to public health authorities?
I think we have a lot of new treatments available, being diet approaches, medication, or even surgical approaches that have good evidence base, but also are cost effective. And what we now need to do is to try and match those treatments with patients who have the disease of obesity. Unfortunately, we don't have any predictors yet. We don't have a blood test we can do that can ask, that can guide us to say, this person should have this diet approach or this person should have this medication approach. So in our practice, what we do is we offer all the approaches to patients, and we allow patients to guide us as to where they will feel more comfortable. And of course, we find that most patients would like to have the approaches that have good evidence, for example, like diet approaches, but also have very low risk. So that's a very popular choice. But I don't think it's the only choice. And I don't think we need to force people to have one treatment above another. But that's a challenge for our healthcare authorities, because we live in this environment where we can't predict the outcome, but we do know that we can, once patients engage and they are successful, these treatments are very cost effective.
Thank you. Do you think the setting for delivery of obesity services is important? Because clearly the specialist secondary care environment will have difficulty in delivering enough to address the whole population problem. And we really have to look perhaps to primary care delivery. What is your opinion on the setting?
No doubt that any disease that affects 15 to 25% of the population cannot be addressed in secondary care. It has to be addressed in primary care. And therefore, we have to work very closely with our primary care colleagues. But there's also an opportunity to work with providers outside of traditional primary care. So really coming into the public health space to empower patients to be successful. So therefore, I would have very little problem with us having a cross approach where we have public sector, private sector, and also all different levels of government involved to address this problem. I think we need multiple solutions, to be successful.
There's a question that has appeared from Dr. Mohammed Iqbal at the Imperial College Diabetes Center in Abu Dhabi. What is your thinking in terms of starting dietary-based weight loss at these times, particularly as there's a suggestion that calorie restriction will reduce immunity? Would you have a comment on that, please?
I think what we are seeing is that patients who have obesity already have reduced immune systems. Now, we know, at least from the data so far, that people with obesity are not more likely to contract the disease, but if they have the disease, they are at much higher risk of complications. Now, at present, we don't have any evidence to suggest that if we take people with obesity and we treat them, we can reduce the complications of COVID-19. But just remember that in the next year, more people are going to die with the complications of obesity without COVID-19. More people will die because of cancer-related obesity or diabetes-related obesity or cardiovascular-related obesity without COVID-19 than people will die with COVID-19 and obesity. So it means that we also have a responsibility to address the diseases that people die from today that are not COVID-19 related. So in our practice, we are comfortable in actually starting treatments as per usual, and to allow patients to reduce their risk of overall morbidity and mortality. But I don't think we have the evidence to claim that this has any effect on COVID-19 related mortality or morbidity.
Thank you. And one of his colleagues, Dr. Nada Lesan, again from Abu Dhabi, asks, the risks seem to be associated with diabetes, but it doesn't seem to correlate very well with glycemic control. Can you comment on the relationship of the risk in relation to glycemic control?
I'm sure that Mike Lean may also want to comment on that in his talk after this, but the evidence, correctly as stated, is only emerging now. There's a clear evidence that patients with type 1 diabetes have a much higher risk of mortality. There's evidence that people with type 2 diabetes have a higher risk of mortality. There's emerging data that suggests that glycemic control does have a dose response effect. So people with the worst glycemic control have a higher rate of mortality, but that evidence is disputed, and I think more evidence is required in this space. Again, I would make the point that COVID-19 is a very important disease right now that really requires our attention, but it should not detract us from the other complications of obesity and the other complications of diabetes, where we know improved glycemic control have a better outcome for microvascular and macrovascular complications.
Yes. And then a final question just before we move to Mike's talk. There's a question from PJ Jennat, who says, is COVID-19, does it have an influence on cholesterol-related diseases, so hyperlipidemias?
One of the strongest evidence that I have seen is in patients with chronic kidney disease and how a reduction in GFR really drives mortality. Now, the reason why I'm raising that is if we see diseases, for example, established heart disease, established chronic kidney disease, and obesity to some effect, that really drives microvascular complications. What we are then also appreciating that this disease is really attacking the microvasculature around the lungs, causing this ventilation perfusion defect. Although the evidence is not yet available, I would not be surprised if we also see an association between cholesterol levels and our poorer outcomes. Because again, it is the same part of the same bit of pathology that is addressed by both of those, both the virus as well as the cardiovascular risk factors, such as dyslipidemia.
Yeah. Thank you very much indeed. So there will be a further opportunity for delegates and also the panel to ask further questions later on. So let's move on, please, to the presentation by Mike Lean from Glasgow